I miss you all so much. Welcome to BRAINCAST, people. This is Pospo kicking off 2021, a year that, to be honest, looks exactly like the previous one. I mean, we're still in lockdown, right? Still in lockdown. Who would have thought that? I remember when the first lockdown was announced, we couldn't believe that it was actually happening. And I have to say that there was a bit of a, bizarre excitement in the air. Maybe because we naively thought, or were led to think, that it would soon all be over. And here we are 10 months later with at least another month of lockdown ahead of us, at least here in the UK. On a good note, though, we have a vaccine and, of course, BRAINCAST, your weekly 30-minute fix on all things brain, from molecular biology and genetics to social psychiatry, ethics, and philosophy. Spread the word to your friends, family, students, uncles, and long-forgotten aunts, and whoever else you think you need to spread the word to, as I do have some really great speakers lined up for you. Speaking of which, we kick off the season with the president-elect of the International Marseille Society, a professor in women's mental health and NIHR senior investigator with numerous awards for her research, including the Association of European Psychiatrists Research Prize and the Royal College of Psychiatrists Bronze Medal. She is the member of several editorial boards, including Lancet Psychiatry, and despite her busy schedule and amidst leading, changing, updating policies for the Department of Health, NHS England, and the World Health Organization, she always finds time to teach, educate, and promote awareness for women's mental health. But most importantly, I have to say, to join us here today. BRAINCAST people, this is Professor Louise Howard. Prof, welcome.
Hi, thanks so much for inviting me. Very excited to be here.
Great to have you here today. So, Prof, they say never take anything for granted in life. And that certainly applies to this webinar. So let's get the basics right. So what is domestic violence?
Okay, I'm going to give you the UK definition. Apologies to our non-UK listeners, just to give you some context. So the definition goes, any incident or pattern of incidents of controlling, coercive, threatening behavior, violence or abuse, whether that's psychological, physical, sexual, financial, economic or emotional, between those aged 16 years or over who are or have been intimate partners or family members, regardless of gender or sexuality. So just to highlight that the WHO definition isn't so broad. It doesn't include family members, and here we're talking about an adult son abusing his mother, for example. It doesn't include that, whereas in the UK we do. And it also doesn't distinguish between repeated severe controlling type of abuse and mutual situational violence where a couple are mutually abusive to each other. So it doesn't distinguish those. And it's important to understand that actually when we're talking about serious domestic violence and abuse, we're talking about what some people have termed intimate terrorism. So the type of thing that Phil Spector, who we've heard about this morning in the news, apparently he used to lock his wife in the house and wouldn't let her out. That kind of intimate terrorism is what we're often talking about when we refer to domestic violence. But this very broad definition, which is what the British Crime Survey and other crime surveys use, is also about any incident. So it's important to just be aware that there's distinctions here that are important.
And sadly, it seems that it is way more frequent than anyone would have thought. A report by the National Intimate Partner and Sexual Violence Survey estimated that approximately 1 in 4 women and 1 in 10 men become a victim of severe violence at some point in their life. And while all people may experience domestic violence, there are some that are disproportionately affected. Can you tell me a bit more?
Yeah, so as you already mentioned, women are disproportionately affected, and particularly young women, so women under 35. Pregnancy is also a time when risk can actually escalate. But there's also other more, if you think about sort of more ecological framework, there's also community level factors that increase the risk. So if you live in a poor area, if you are poor yourself, if you live in a community that's violent, there's also an increased risk of domestic violence in the home. If you have substance misuse problems, and we'll come on to mental health problems, but also if you're from particular ethnic backgrounds, you're at increased risk, particularly of particular types of domestic violence. So, for example, honour-based violence. So there is definite differences in different groups, but the very strongest risk factor is sadly women, which is why I've ended up researching this area, because I was researching women's mental health. I hadn't planned to research domestic violence. It's a hidden problem, and it was even more hidden when I started looking at women's mental health 25, 30 years ago. But I've ended up doing a lot of research in this area because it affects women's mental health so much.
And we're lucky you made that decision. So Prof, the European Union Agency for Fundamental Rights, they published a report called Violence Against Women, an EU-wide survey. So what is striking is the contrast between the high prevalence of violence against women and the reporting of these incidents to the police and other services, with only 1 in 3 victims of partner violence moving to the courts. So what are the barriers to reporting domestic violence?
Well, the main barrier is fear, and it's fear of consequences, I think. So people are very scared of the perpetrator finding out, and that leading to increased violence. And we know that can occur if the disclosures are not handled safely. Then people are very scared that they will be told they have to leave. Sometimes they might be told, well, you know, you have to leave right now, otherwise we're not going to help you. And actually, it's a very complex process if one wants to leave. And that might not be realistic. For example, you might not want to uproot your children from their school. You might be really scared that you're going to be blamed for not protecting the children, which can happen. And again, it's fear of statutory agencies. If you have insecure immigration status, you're going to be even more concerned about reporting to a statutory agency, and yet it is those women that are particularly at high risk of abuse for obvious reasons. So there's lots and lots of fear, but there's also shame, embarrassment, and the fact that people fear they may not be believed, and sometimes they weren't believed when they did disclose. The people that they most want to disclose to, that they feel most happy about disclosing to, are actually health professionals. So we have a particular role, but it can even then take on average 7 to 8 contacts before somebody will disclose what's happening.
Wow. And as you would expect, you know, being exposed to domestic violence does not come with particularly favorable mental health outcomes. So what is the impact on the victim's mental health?
Well, it's across the diagnostic spectrum. You can get depressive symptoms for the first time, and longitudinal cohort studies have found that, you know, people with no mental health problems at baseline who then experience partner violence do then develop depressive symptoms, anxiety symptoms, PTSD symptoms. They also reach criteria for clinical disorders, and we showed that in one of our papers. And what's also really important to understand is that it's people in contact with secondary care that are most at risk of having had a severe impact on their mental health, and also severe exacerbations if they're then subsequently abused after experiencing something like bipolar disorder or schizophrenia. So much so that when we used British crime survey methods and we went and interviewed SLAM service users and also service users in Camden and Islington, what we found was that they were horrifically higher risk of having experienced domestic violence. For example, 70% of women had experienced at least one incident since the age of 16, and in the last year, over a quarter had experienced a severe incident. Now that's much higher than the general population rates that we used for comparison, even after adjusting for poverty and for other socio-demographics. So our patients, as psychiatrists or other mental health professionals, our patients are at particularly high risk, and yet we are really unlikely to know about it, because we did one review, 10 to 30% of what was actually happening was actually being disclosed to the clinicians.
Wow. And what about the other way around? I mean, I don't know if you were referring to this study that you led. It was published in PLOS ONE a few years back, when you looked into mental health disorders and the chances of being a victim of domestic violence. So what did you find there?
Yeah, so I mean, of course, a lot of the studies are problematic because they're cross-sectional surveys, but if you look at longitudinal studies, and a very good systematic review actually published by another group, Karen DeVries et al., showed this really nicely, that if you look at longitudinal studies, there's a bidirectional association. So if you've already got a mental disorder, you are at increased risk of experiencing domestic violence. If you are a victim of domestic violence, you're more likely to develop a mental disorder. So it goes both ways, and it's complicated because there's all sorts of other factors that are leading to both the experience of being a victim and having a mental disorder. For example, if you grow up in an environment where you're exposed to violence in the home, then you're more likely to become a victim, actually, of domestic violence. You are also more likely to be directly abused. About 40% of children growing up where there is domestic violence are also being directly abused themselves. So, of course, we know that abuse in childhood and witnessing violence is associated with subsequently being a victim of domestic violence. And, of course, those factors are also associated with being somebody who develops a mental disorder. So it's a very complex interplay of these different factors.
I mean, as you've already alluded to, it's really, really complex. Now, you authored another study in 2019 where you conclude that when compared to the general population, you found that men with mental disorders, apart from those with autism, were more likely to perpetrate against women. Now, this can be misinterpreted that mental illness is essentially causing domestic violence, but this is not true, right?
Yeah, so what we found was that there's an association between mental disorders and perpetration of partner violence, and many others have also found an association. The big question, of course, is why? What is going on? What's the causal pathway here? And what we found was that actually most of this perpetration of domestic violence could be attributed to substance misuse and also familial factors. So we did a sibling control study design so that we could control for some of the familial factors. So growing up, like I said, in a violent home, for example. So those factors were controlled for. Therefore, this relationship seems to be explained by substance misuse and these other familial factors. So it's not that if you have schizophrenia, that in itself makes you a perpetrator. In fact, we didn't quite find a statistically significant association of schizophrenia, but of course it's a rare disorder. But let's say for bipolar disorder or depression, we are not saying that that in itself is the cause. It's a multiplicity of factors that led to the disorder as well as the violence. But that's not to say, of course, that there aren't symptoms of mental disorders that may indeed be important when thinking about it. So, for example, irritability is a classic symptom of depression, and particularly there is a gender difference in irritability, and if one is also using alcohol, we know that alcohol is a trigger. So there is a reason to think that actually if you're suffering symptoms, that might be an additional factor that leads you on to actually perpetrating violence. What it also means is that although there's no direct causality, probably, we know also that we in mental health services are more likely to see perpetrators maybe than other professionals and other people in the general society. And that means we have a responsibility to also identify and respond to perpetration of domestic violence. And we know from statutory domestic homicide reviews and also from our local MARACs, these multi-agency risk assessment conferences, where high-risk victims and perpetrators are discussed, we know that around 2/3 have actually been in contact with mental health services, and that's both for the victim and for the perpetrator. So mental health services definitely have a lot of perpetrators potentially in contact with them, as well as a lot of victims. So it's important that mental health professionals really know about identification and safe response.
Of course. Thank you for clarifying, Prof. And while the intimate partner violence has been extensively studied in heterosexual relationships, it doesn't mean that it's not prevalent in same-sex relationships. So what is the situation there?
Yeah, so as you say, there's been a lot of research on heterosexual relationships and much less on other types of relationships. There's conflicting data. The studies aren't great, but what it certainly suggests is that the rates are comparable. They may be a bit higher. There is some evidence to suggest they may be a bit higher, but other studies suggest that the rates are comparable. There is, however, one group that particularly stand out at being at high risk of being a victim, and that's transgender people, and they are at probably a doubling level of prevalence. So again, all sorts of complicated reasons probably for that, and it's pretty preliminary emerging evidence, but it does suggest that we need to be particularly aware, and bearing in mind, of course, that trans people also are more likely to have mental health problems and suicidality. There is some evidence to suggest from some of the domestic violence sector that the trans people that they are seeing are particularly likely to be presenting with mental health problems as well.
Now, an older paper by Daniel Whitaker on American Journal of Public Health. So what they did is that they looked into a national sample of young adults in the States. Now, they found that reciprocal violence was about as common as non-reciprocal violence, with about half of the violent relationships being characterized by reciprocal violence, i.e. perpetrated by both partners. I would expect that those numbers would have been way lower. Is this the same here in Britain?
Why would you expect the numbers to be lower, I wonder? I mean, yeah, absolutely. Violence begets violence. And it's probably more common, actually, than unidirectional. But of course, you know, violence does beget violence. And I think when you're thinking about relationships, the real issue is it's not going to be surprising if there's mutual physical violence. But is there an imbalance of power? Is one of the dyad very fearful and afraid of what might happen, and who is getting the worst impact? And sadly, it's usually women that end up in hospital as a result of violence rather than men. And so we need to, when we're assessing these relationships where there is mutual violence, need to be thinking about where is anybody, you know, where is the power imbalance? Who is afraid of who? And asking individually, you know, are you afraid of your partner? What are you afraid might happen? What's the worst that ever happened? That's a very powerful question, I find, because people are so embarrassed, they're not going to tell you spontaneously about the worst thing, but then you might discover that somebody's actually, you know, had an attempted strangulation. It's not that uncommon once you start asking. So mutual violence doesn't surprise, but what's really important, I think, is about where is the power imbalance? What is the risk here?
And it's not only the partners that get affected, right? You know, I was reading an old paper by Sandra Stith, published, you know, talking about the intergenerational transmission of spouse abuse, especially, I mean, suggesting essentially that growing up in an abusive family is positively related to becoming involved in a violent marital relationship. So what is the effect on children?
Yeah, so we know that even in utero, the babies are being affected. So that's probably due to the stress response that the mother is experiencing. We know that the babies are more likely to have low birth weight and be small for gestational age. And of course, that's associated with all sorts of problems in terms of development. And then if the abuse continues into the postnatal period, we looked at ALSPAC, southwest in England cohort, and we found that the children that had been exposed to antenatal and postnatal violence had behavioural problems even by the age of 3.5. Longer term studies, you know, the ACEs, the classic adverse childhood experiences, domestic violence is one of those ACEs, and we know that again is associated with much longer term mental and physical health problems. So there's all sorts of potential mechanisms there. We also then know that those people, as you say, are more likely to either be a victim, but also sadly at increased risk compared with those who haven't been exposed to violence of becoming a perpetrator. And maybe it's not that surprising, because if that's the family that you've grown up with and that's how you know understand relationships to be, some of my patients have sometimes said, I don't know how to be a parent. So, you know, they need a huge amount of support to help them understand how to stop this intergenerational transmission. And there's some really interesting, innovative interventions that are being developed actually for couples who want it to be different for their children, but actually don't know how. And
then came COVID, of course. I mean, how can we even do a discussion without mentioning this bloody C word? So, reading a report by Megan Evans, published this December at the New England Journal of Medicine, she describes domestic violence as a pandemic within a pandemic. It concludes by calling it a public health crisis. Now, here in the UK, police recorded 259,000 domestic abuse offences between March and June last year, which is roughly 7% up on the same period in 2019. Leading to Sadiq Khan, that's the mayor of London, mum, you know, home is not always a safe place for everyone. This is what he said. So did things go that bad?
Well, I mean, I would argue that actually before COVID, things were pretty bad. You know, domestic violence was endemic, as you've already highlighted from some of the studies that you've very conscientiously been reading before this this podcast. Yeah, things have got worse. So there's lots of evidence from police reports internationally that they've had more calls. And it's not that surprising, really, because you couldn't really create a situation that could be worse for somebody that's a victim. You know, they're now stuck at home. Maybe both partners are working from home, or the abusive partner is now working from home, and the other person, the victim, is potentially looking after the children. They're socially isolated, not getting the normal support, can't get some of those other outlets for escape, so no longer talking to people at the school gate, or seeing people that they would normally, friends who might be saying, look, this is abusive, you need to leave, you need to talk to somebody about it. So there's all sorts of reasons why this social isolation that we're all experiencing is particularly traumatizing and dangerous potentially for domestic violence situations. We don't yet know if there's going to be an increase in domestic homicides, but obviously there's usually 2 a week by a partner or ex-partner, and I want to highlight that actually the risk is higher when you leave somebody. So the first few months after you've left a domestic violence situation is the highest time of risk, because that is when the perpetrator is most likely to be absolutely furious and try to kill you. So domestic homicides are most likely after somebody leaves, and that's why people often don't want to leave. They're very, very scared. And how can you make it very safe for somebody to leave? So we don't yet know, but there was a hint in the data that there was an increase in domestic homicides as well. And as a clinician, there's the confidential inquiry into maternal deaths always has this very depressing section on domestic homicides. There's always some domestic homicides in these inquiries, but they've highlighted that so many of the small numbers, but the suicides and the domestic homicides, there's a high prevalence of domestic abuse there. So there's lots of reasons why this has become a really urgent public health issue, but it was already a public health issue. It's just that somehow COVID has really highlighted it to people. Not only has it grown, but I think also there's been more awareness because it's grown, which I hope is in the long term helpful.
Which actually brings us to the comment that you co-authored with Vishal Basar, Kyla Kirkpatrick, and Marilia Calcia at the Lancet Psychiatry late last year. So you talked about gaps in training, research, and policy relevant to lockdown and domestic abuse perpetration. So tell me a bit more, what are these gaps you're talking about?
Well, I don't know about you, but when I was training, I didn't learn anything about domestic abuse. And it is creeping into the curriculum, but in a very small way. And when you think about the huge public health impact that domestic violence has, it is very striking that so many clinicians I encounter don't know how to safely ask or how to safely respond to domestic abuse. They don't know about MARACs in this country. That, you know, there's a big training gap, and maybe it's worse for those people that are already been trained, because actually we're now just sort of really getting to grips with this endemic problem. So I think there's a CPD gap as well as a training gap. I think there definitely is change. There's much more understanding that it's an issue, but there is still, you know, we haven't quite got there in terms of safe response. And certainly women themselves say they're often not believed, that, you know, all sorts of barriers to disclosure, but also not very helpful, safe responses. And during COVID, that's become particularly problematic, because of course so much of service delivery from an outpatient community perspective is online, and you don't know who else is in the house. So how do you assess safely when you're doing those assessments? And actually, of course, you can't assess safely if you don't know who else is in the house, and you're going to have to ask closed questions rather than open questions about relationships, so that you can get those yes/no answers from somebody that knows that somebody else might be listening in, for example. So COVID has really made things very, very complicated, and it means that the training that we've already done and the resources that we've already produced, that you're very kindly going to include in the chat, have had to be updated a bit for COVID. And there's been some fantastic work done in Oxford looking at evidence-based guidance around a whole range of medical issues around COVID, and they have produced some really helpful guidance around domestic violence and abuse. So I'd encourage people to have a look at that as well as look at our more general resources, because those hopefully will be helpful.
And Prof, since we mentioned about this gap in training, so I know that we need a couple of hours for this, but for this question, but how can we recognize domestic violence, and what is the risk if we don't do it right?
Okay, so yeah, like I need an hour and a half, but I guess, how do we recognize? The first thing is to understand that all of our patients could have been victims of domestic violence. So people often talk about indicators of domestic violence, but when it comes to mental health services, actually it's so common. Remember, 70% of women and nearly 50% of men have experienced some incident since the age of 16, and that there's this very high prevalence of current domestic violence, around a quarter, and for the women and 10% of the men. So that means we have to ask about it at every assessment. We can't just think that it's only people that mention it. It's not just women for us as well. It's men with severe mental illness as well. So we need to assume that the person in front of us may be a victim. And until you start asking regularly, you realize just how profound your unconscious bias is, because when I started to ask regularly and realized just how big a problem it was, I would get middle-class professionals coming in and I would be asking, and it would be only when they said, oh, we do have difficult arguments, and I would say, well, what exactly happens? Is there ever physical violence? What's the worst that's ever happened? When you start to really probe and you ask very specific questions about sexual abuse and physical abuse, you get alarming answers back, and you think, gosh, I would never have dreamt that this woman had allowed herself to have, to have a attempted strangulation and still be in that relationship. What's going on here? So we need to understand how complex these situations are, and we need to make sure that we identify safely in a private environment. We don't use interpreters from the communities that the women are from, etc. And then we need to make sure that we only ask when we know how to respond. No point in identifying and then not knowing what to do with it, because that's not going to be very helpful. So we need to understand the referral pathways that an individual organisation has set up, and there are great pathways in SLAM now. We need to be able to support the woman, not say, oh, well, all your problems are down to that and there's not much point in me seeing you. That's really unhelpful. Women don't find that helpful, and they've told us that. So we need to be supportive, help the woman make a referral herself, potentially to the domestic violence sector. Potentially safeguarding issues are going to be often very prevalent, especially when there's children, but to do that in a supportive way with the woman. And of course, if it's a high risk case, then potentially refer to a MARAC. If it's very, very risky, then you might have to phone the police. So there's all sorts of things that you need to do to safely identify and respond. Because if you get it wrong, potentially you've got somebody where the perpetrator might find out and you might end up with a homicide. And there have been plenty of homicides, even within our organisation. There have been domestic violence homicides, which isn't surprising, it's inevitable. But it does mean that there are potentially things that we could do to try to prevent that.
That's extremely, extremely helpful. So, Prof, we spent 30 minutes talking about domestic violence, and it seems that essentially it is a vicious circle. So how do we break it? You have 20 seconds, or maybe 30.
Okay, use the WHO acronym, LIVES. Okay, so listen empathetically, sensitively, safely, inquire what the support's needed, validate the person that you believe them and that you can help them. E, I can't remember what that stands for, but essentially what you're then doing is you're offering them support, that's the S, and you're making sure that whatever you're doing is in a safe way for that woman. So the LIVES acronym, which is in the resources that I've given you, but I can't remember the E, is a really helpful way of thinking about the steps that you need to take to get support. I think mental health professionals really can make a difference because it's so common, and we therefore really can help break that intergenerational transmission.
Amazing. BRAINCAST people, Professor Louise Howard, thank you so much, Prof. That was really enlightening. And from women's mental health to money for mental health. Well, kind of. Next week, we will delve into the fascinating and at times controversial world of health economics. Why cost should be a consideration when making treatment-related decisions? Do economics have ethics? You bet they do. And seeing there would have been some degree of irony having a Greek talk to you about economics amidst a global recession, I will leave that to the head of King's Health Economics, Professor Sarah Byford. Until then, Pospo and BRAINCAST for mostly learning, over and out.